everyone. Greetings from Malaysia, and a very big congratulations to the Association of Women Endoscopists for the success of your 6th meeting. Thank you, Mary Lee, Sonia, and Phoenix for this kind invitation, and as well as for initiating the wonderful collaboration with WICNAP. It was really great to meet all of you in Bangkok, and I really look forward to more of that. My task today is to talk to you on Transcolonic EUS-guided access. So we know from our previous speaker, Nontali has already told us about how EUS is now part of the armamentarium for endoscopy, and the role of EUS FNA, FNB to obtain tissue for histological examination from extraluminal lesions within the GI tract has long well been established. And this has considerably influenced the staging of esophageal, gastric, rectal, pancreatic, hepatobiliary, and even lung cancers. And progress in this field has also accelerated in the realms of interventional EUS. In stark contrast, the application of this technique to fulfill even the most basic need of obtaining biopsy specimens from lesions in the lower abdomen and pelvis by intubation of the colon has been sporadic at best. So when we look at lower GI EUS, this can be fairly challenging, and I will share why that is so with you in the next couple of slides. We are familiar with the day-to-day evaluation of submucosal lesions. Once in a while, we find this incidental rectal nodule that turns out to be a neuroendocrine tumor, or we may perform an EUS for submucosal lesions that turn out to be a GIST tumor. And I've had a couple of patients where it's actually been ectopic endometrial tissue. And EUS is routinely used for the staging of rectal cancer. It has been performed for transrectal biopsy of perirectal lymph nodes. There have been cases of transrectal drainage of pelvic abscesses and collections. The most common cause of a pelvic collection is an anastomotic leak following colorectal surgery, and abscesses tend to arise from perforation of the GI tract. So linear EUS has been shown to be effective and safe, but we've kind of stopped at the rectum. For proximal pericolonic lesions, EUS seems to be technically difficult in scope insertion, and we are afraid of the risk of perforation. So why is that so? When we look at the pelvic rim, you can see that below the pelvic rim, the rectum is fairly straight, and we have an easier access to any collections that are within this area. And above the pelvic rim, there is a sharp angulation where the rectosigmoid turn takes on, and it is hard to maneuver the scope. So what are the challenges? Number one, the sigmoid colon is highly mobile, and trying to achieve a stable position from which we can safely access collections is more difficult than from the rectum. Currently available curvilinear echoendoscopes also have a relatively oblique camera visualization, and the limited tip deflection makes navigating through the tortuous sigmoid colon difficult. And thirdly, the sharp angulation of the sigmoid turns may make it difficult to puncture the collection on face rather tangentially, and this increases the risk of perforation. Almost 20 years ago, so back in 2003, this is Mark Giovannini, one of the pioneers of EUS, who described the first transrectal drainage of deep pelvic abscesses. And what Mark showed is, this has revolutionized the interventional EUS in the sense that he showed that if you can localize the area to be punctured, and you're able to put in catheters and plastic stents, and we're able to drain these abscesses, and we are able to improve the outcome of the patient, which is more cost effective, and this can be even performed by the bedside in critically ill patients. And this is a very nice systematic review and meta-analysis in endoscopic ultrasound in 2021. This looked at 8 studies involving 135 patients and basically summarizes that EUS-guided pelvic abscess drainages offers a viable alternative that can minimize the need for surgical intervention. And EUS pelvic abscess drainages have a high technical and clinical success with low rates of adverse events. It is best suited for unilocular abscesses with a mature wall of at least 4 centimeters. And EUS pelvic abscess drainages should be strictly avoided in patients with ascites or if the abscess is more than 2 centimeters from the bowel lumen. For collections that are smaller than 4 centimeters, it is thought that IV antibiotics should suffice. This is a study comparing the outcomes between EUS-guided transcolonic and transrectal drainage carried out by Ramesh Jibang in Shyam's group, published in 2013. It's a retrospective study of all patients who underwent EUS-guided drainage over a 7-year period. Abscesses were drained by a standard single-step EUS-guided technique with the deployment of double pigtail stents with or without catheters. There were 38 patients, 11 underwent transcolonic, 27 underwent transrectal drainages. There was no difference in the rates of technical success, treatment success, or complications. When evaluating by etiology, they found that patients who had drainage for diverticular abscesses had a significantly poorer outcome as opposed to those with post-surgical leaks or perforated viscous. And it is thought that, diverticular abscesses are often multiloculated, and the highly viscous nature of these abscesses contribute to treatment failure. And then with time, with the emergence of the lumen-opposing metal stents, and that has made drainage in various parts of the GI tract much easier. So this is a retrospective case series of 5 patients where they used the hot axios, and this was carried out in their endoscopy suite without fluoroscopy. There was complete resolution of these pelvic fluid collections within 2 to 3 weeks. Stents were removed within 2 to 3 weeks, and this is advised because of the risk of migration if left longer and embedment. There was no issue with fecal contamination because the large stent caliber and the intrinsic negative luminal pressure ensured adequate drainage. Spontaneous tract closure after stent removal was confirmed on follow-up CT. So what are the general principles of EUS pelvic abscess drainage? So obviously antibiotics, IV antibiotics has to be started prophylactically during and after the drainage. We need to ensure the coagulation status of the patient is normal. The bowel should be prepared as well as possible. We need to make sure we have surgical and interventional radiology backup in the case of perforation. The urinary bladder should be emptied and catheterized, and the Foley's catheter being in place is a guide as to where the bladder is. And even though the procedure is very similar to a sigmoidoscopy, it can be quite uncomfortable, so we have to ensure there is adequate anesthesia. Procedure is carried out in the left lateral position. Equipment, we need a therapeutic scope with a large working channel to allow for the 19 gauge needle. And of course, CO2 is recommended. What about the techniques? There are various techniques. The first is the traditional needle aspiration and wire-guided access, for which we need fluoroscopy. And then we have the integrated system, whereby the Giovannini needle is a one-step puncture, dilatation, and stenting procedure. And of course, we have the LAMS, the lumen-opposing metal stents as well. What about the transcolonic approach? All these have been transrectal pelvic abscess drainages. So transcolonic, there have been a few reports and case series. So back in 2005, Sasaki described in 22 patients, they used the curvilinear scope with an overtube and a guide wire, and they were able to evaluate submucosal and extrinsic masses of the colon and rectum. And then in 2010, Ken Bin-Muller's group was one of the first to use the forward-viewing Olympus echo endoscope to evaluate right colonic subepithelial lesions. And this was in 15 patients, and they could reach the cecum within 10 minutes in every case. In the same year, in 2010, Uchida also published the ability to evaluate extracolonic lesions and perform EUS-FNA with the forward-viewing echo endoscope. So the evolution of EUS, we have moved from radial to linear to forward viewing, and we're all familiar with this, where we know that the radial scope has a very nice 360 degree transverse cross-sectional image, but we're not able to carry out any intervention. And then the linear scope has an imaging view of 180 degrees, side viewing. We have an elevator, and we're able to carry out FNA, FNB, and drainage procedures. And then we have the forward viewing scope, where I will show you in the next slide. The needle doesn't come out tangentially, but it is head on. So this is the forward viewing scope by Olympus, and you can see the difference between the forward viewing scope and the conventional linear scope. So the angulation in the forward viewing scope is excellent at 180 degrees as compared to 130 degrees, but there's a compromise in the ultrasonic view, whereby in the forward viewing scope it is only a 90 degree, whereas in our conventional linear echo endoscope we have a 180 degree view. The other advantage of the forward viewing scope is that it has a very short distal end as compared to this, and we're able to reach the target object closer. In terms of puncturing, it is straight head on as opposed to a tangential approach. And if we look at this diagram, you can see that with the forward viewing scope, you are actually nearer to the target object as opposed to a tangential view. I'd like to share with you the larger series of transcolonic evaluation with the forward viewing echo endoscope, and this is by Nithi and colleagues, published in Clinical Endoscopy in 2020. And this was all during the pandemic, and I was asked to write the commentary on this paper as well. So in this publication, it was a retrospective study of 13 patients over a 3.5-year period. All these 13 patients underwent transcolonic EUS-FNA of extracolonic lesions using the forward viewing Olympus scope together with fluoroscopic guidance. FNA was performed successfully in all patients with 100% technical success, with a median time of just 31 minutes. Sensitivity, specificity, and accuracy of EUS-FNA for detecting malignant lesions in the study were 91%, 100%, and 92% respectively. And there were no adverse events associated with the EUS-FNA procedure. And the authors attributed the favorable results to two key elements. The first was the use of the forward viewing scope, which enabled easier intubation and navigation to the right side of the colon as compared to the curvilinear EUS scope. And the second element was that they used fluoroscopy to help determine whether the position of the tip of the scope was close to their target lesion. And they also commented that for lesions that were small but visible endoscopically, that was quite easy to access. However, smaller extracolonic lesions were quite difficult, and they needed fluoroscopy to help to find those lesions. They also carried out transrectal FNAs with the forward viewing scope, and they found that it was quite easy to maneuver the scope within the limited rectal space. This is a case report of using the forward viewing scope again, and the authors managed to reach the cecum, and they were able to perform an EUS FNA with a 25 gauge needle, and they got enough tissue to make the diagnosis of a IgG4 related sclerosing mesenteritis mass. And in this review article in 2020, they suggest that the forward viewing therapeutic echo endoscope is actually widely available, but it's not frequently used. And this forward viewing scope actually allows us to view the target area better. And Todd Barron, in his case study, showed that for even biliary drainage, stent advancement was possible without needle tract dilatation and minimizing the risk of luminal leakage. And even for EUS-guided choledochoduodenoscopies, which are usually performed in the long scope position, in that position, with the traditional curvilinear scope, we have oblique views, and the axis of the working channel points towards the liver hilum. Manipulation can also be limited. With a forward viewing scope, the working channel is perpendicular to the target, and the shorter tip also allows for easier manipulation. And this is a case study by Kawakami in Endoscopy 2020, basically going back to the curvilinear scopes. And this is a novel linear echo endoscope, at this time by Fujifilm, and they showed us that it was possible to reach the cecum. They used a guide wire with fluoroscopic guidance, and they reached the cecum, and they were able to see this extracolonic lesion, and EUS FNB was performed with a 22 gauge Francine needle, and they got good tissue to confirm adenocarcinoma. And if we compare, this is the standard curvilinear, this is the forward viewing, and this is the Fuji novel echo endoscope, and you can see that it has pretty good angulation, and it's slightly slimmer. So this is just one case report. And again, in 2023, this year, again, with the standard curvilinear scope, Kawakami was able to reach a lesion in the tail of the pancreas in a patient with surgically altered anatomy, this time using, again, an overtube to get good tissue. So, in conclusion, ladies and gentlemen, you can see that there are no large multi-center cohort studies. Everything has been case reports and case series, and you can see the challenges with transcolonic EUS. I think we are quite convinced with transrectal approach, but I think there is great potential. But we need larger studies. Some of the potential challenges of the transcolonic drainage may be overcome with the use of the forward viewing scope, and we look forward to more novel echo endoscopes, and of course, we could try with overtubes as well. And I think it's incredible. People like pioneers like Mark Giovannini and Ken Bin Muller and everyone over the decades who have been pushing the boundaries in high volume centers where there's expertise, people who understand the anatomy, understand the procedure and the tools, and we keep innovating and developing technology to move forward. But I think for the time being, given the limited evidence, I think we have to use a multidisciplinary approach. Each case has to be assessed and discussed with the gastroenterologist, the surgeon, and the interventional radiologist to determine the optimal treatment strategy. And with that, ladies and gentlemen, thank you once again for this wonderful opportunity and for WICNAP to collaborate with AWE, and we certainly look forward to many more. Thank you once again.